Hey folks, in this very quick talk, we're going to cover chest tubes and pigtails, specifically for spontaneous pneumothoraces. Now, this recording of this lecture is going to be available at the web address here, jackcm.cc/psp. And most of the information I'm using for this is from Emergency Medicine Cases podcast. They had a fantastic review of this entire subject on episode number 158. And if you go to their website, they have all the show notes. They have some great links and algorithms and other resources. So you should definitely check that out. This isn't going to be a deep dive into literature and data, but it's going to be a kind of a synthesis of the data out there to try to give us a general approach into what to do with these patients with a spontaneous pneumothorax. So obviously, pneumothoraces that come in multiple different flavors. We're going to start by thinking of two different patients. Patient 1 on the left is a 25-year-old male who experienced a coughing fit and then had some pain in his chest and came in. And the one on the right is a 55-year-old male with a long history of smoking who suddenly has shortness of breath. Now, both these patients have pneumothoraces, a little different size. We're going to see how the size of the pneumothorax, see how the history of the patient, and how the symptoms all kind of play into deciding what we should do. Now, there are various approaches to this. But here's some things that should go through our head when we're trying to figure out what to do with these patients. If you can answer these questions and then turn to the evidence, you can kind of make an informed decision of how to treat patients with spontaneous pneumos. So first off, are they sick? This can mean severe respiratory distress, hypoxia, hypotension. All of these things are obviously going to be treated immediately based on the situation. So those aren't necessarily the patients we're thinking about right now. Is this a secondary pneumo? Again, this talk is on primary pneumothoraces. So secondary pneumothorax is due to underlying lung disease, most commonly COPD, but also TB, necrotizing pneumonia, cancer, connective tissue disorders. All of these patients with pneumothorax from these causes have a higher risk for continued air leak, and so they're generally excluded from the treatment algorithms that we're going to discuss. What kind of symptoms is the patient having? So this is very subjective, obviously, but this broadly separates these patients into one classification of no or mild symptoms and a classification of significant symptoms, and that can help you make your decisions. These symptoms could include tachypnea, tachycardia, chest pain, dyspnea, hypoxia, and this will help you down the road when you're going through your treatment pathway to determine your intervention and your disposition. So on the subject of size, there's lots of different classification systems. And the American College of Chest Physicians is probably going to be the most commonly that you hear of in the US, and that is the blue arrow in this image here. And the way they identify a large pneumothorax is they take the distance from the apex of the lung to the cupula, and if that's greater than 3 centimeters, then that is a large pneumothorax. Kind of similarly, the British Thoracic Society has their classification, and that is the red arrow, and that's the interpleural space between the hilum, and at the space of the hilum between the lung and the lung wall. And if this is greater than 2 centimeters, then that's considered large pneumo. There's a light index, which takes multiple measurements. And on the right is the Collins method, which again takes multiple different measurements, kind of adds them all together. So the evidence on all these is kind of all over the place, but it's good to use multiple ones to kind of really make a definitive decision. If you're using 2 or 3 of these and they're all adding up to the right number to get either a small or large pneumo, it kind of confirms what you're thinking from the other measurements. So I like to kind of use multiple ones for each patient. Now, as you can imagine, there's a great variability around the world when it comes to how to treat these based on size and symptoms. But to put things in broad terms, the US management generally is more invasive than the European. Europeans tend to have less invasive management and also tend to send more people home. There's lots of reasons for that. One has to do with medical systems. When you have a national health system, you're able to follow patients easier. Patients are known to have better follow-up care. And obviously, liability culture within different countries is going to add some variability. So do know there's lots of variability across the map. In general, most people at least agree that large bore chest tubes for primary spontaneous pneumothorax, they're out. We should not be doing these anymore. Even when it comes to trauma, we're not doing them as much. There's literature coming out using pigtails and small bore chest tubes in trauma patients as well. But talking about purely spontaneous pneumothoraces, primary ones as well, we really should not be using large bore chest tubes. There isn't any evidence that says there's any benefit, and we do know that has increased pain, increased length of stay, increased reaccumulation of the pneumothorax as compared to pigtails, and so we generally should not be using these. So we've looked at our patient, we've determined if they're sick or not, whether it's secondary or primary, we've determined the symptoms they're having, we've determined the size. Now we can start going down a pathway to determine what to do with these patients. This pathway is from North York General, so this is a Canadian facility. When we look and search for pathways, evidence-based pathways, you'll find most of them are from Canada or Europe. And I think that kind of mirrors, again, their culture to try to send more of these patients home and maybe treat with things like needle aspiration or pigtails or other devices that we'll discuss. So just keep that in mind. So we start with our primary spontaneous pneumothorax. And from there, we can divide between symptoms. So either small symptoms or mild symptoms or what they call symptomatic. So symptomatic is going to be more significant symptoms like we talked about before. So we focus first on that left side. So either our small pneumo with mild symptoms or a large pneumo with mild symptoms that meet what they call the conservative approach criteria. That's age less than 50. That is a primary spontaneous pneumothorax, mildly symptomatic, so able to mobilize, vital signs normal, reliable and able to return, and no planned air travel. If you have that despite having a large pneumo, you can consider sending them down this pathway as well. You can see that the first step in this pathway is observing in the ED and repeating a chest x-ray in 4 hours. So from that repeat chest x-ray, we look at either no change or increase in size. So if we have that patient who meets these criteria, we repeat a chest x-ray in 4 hours, there's no change, based on the evidence they use, and most of the evidence that we see out there, we can safely discharge home without a chest tube. Now, the consideration for this is that the patient does need follow-up within 24 to 72 hours for a repeat chest x-ray. So obviously it's not going to fit every system, it's not going to fit every patient population, but there is evidence to support this practice. Now let's say at that repeat chest x-ray after 4 hours, our pneumo is actually increasing in size. So based on this pathway, this patient isn't an immediate candidate for discharge. If we take this pathway over to the other side, we can either get there from the initial chest x-ray increasing in size, or if this is a patient with a large symptomatic pneumo. And we're left with two options on this pathway. Now option one is a small bore chest tube. So what they mean by that is likely a pigtail in most circumstances, or just a very small chest tube that kind of acts like a pigtail, plus a Heimlich valve. So I put a picture of a Heimlich valve here because I often come across some confusion with residents and with staff as to what a Heimlich valve is. Heimlich valve is a very simple device. It's a little clear tube there and essentially has a rubber hose, almost like a Penrose drain inside, and that acts as a one-way valve. So on the blue side, air escapes from the lung through the tube, through the Heimlich valve, out the clear side. And that doesn't allow air to come back in. So if there's increased air accumulation from the pneumo, as the patient breathes, it'll escape out, but it can't come back into the device. So based on this pathway, they place the small bore chest tube, they place a Heimlich valve, and then they watch for improvement. They repeat that chest x-ray in 1 hour. And then they check for improvement. Now, if the lung has expanded, meaning there's no air leak, what they do is close the valve off. And the way they usually do that is a stopcock. So they'll have a three-way stopcock and close off the system so that it's no longer acting as a one-way valve. They then obs the patient and watch for 4 more hours and repeat a chest x-ray. If there's no change in that x-ray, meaning there's no reaccumulation of air, no air leak, they actually discharge home without a chest tube. So they'll remove that tube and send the patient home, again with follow-up in 24 to 72 hours. If after they close that valve and repeat the chest x-ray, there's actually an increased size of the pneumothorax, then they open the valve back up and get another repeat chest x-ray to see what kind of improvement they have. If there's minimal improvement, they'll attach to suction, and there's a different suction pathway here. It usually ends up in the patient getting admitted. Or if there's improvement with that repeat chest x-ray, they'll go ahead and send the patient home with the chest tube in and the valve open. So that Heimlich valve is still working to relieve any increased air. The whole point of this pathway is to avoid reaccumulation from an air leak. So along the way, you're multiple times checking for evidence of an air leak from whatever caused the pneumothorax. So you're trying to prove to yourself that there's no longer an air leak. And so you can see that's kind of the whole point of this whole algorithm here. Now at that repeat chest x-ray, after the pigtail or small bore chest tube were replaced with the Heimlich valve, if there's minimal improvement, then would they go ahead and place the patient on suction. So usually with a water seal device, so here is the atrium device, similar to the ones that we use. And essentially what that does is adds a water seal. So the water seal acts as a one-way valve, so air can pass out, but it can't come in. And also will collect any fluid that comes out of the tube as well. And they hook that to suction. And then they do a repeat chest x-ray after 1 hour. Now, at this point, the pathway ends in admission no matter what. It just depends on what they do with the patient after that, with suction and other maneuvers as well. But once they've placed the pigtail or the small bore and they've seen minimal improvement, they go ahead and keep this patient in the hospital just to make sure that there's no reaccumulation, the patient does well. Now that's option 1. Option 2, we're not going to see as much in the US, and that's needle aspiration. It's actually a pretty successful procedure. When you look at reaccumulation rates or success rates, it is lower than pigtail and chest tube placement, but it's much less invasive. So it actually has a role for certain patients who really don't want to stay in the hospital, and you're really not sure you want to send them home with a chest tube or a pigtail in. Needle aspiration can actually come in handy. So it's a pretty easy procedure to perform. So you should know about it, but you just won't see it much in the US. But option 2 on this pathway is they do the needle aspiration. And much like the pigtail catheter, they go ahead and repeat a chest x-ray and look for improvement. And if there is improvement, they go ahead and send the patient home without a chest tube because they did a needle aspiration. If there's not improvement, they go back to option 1 and place a pigtail or a small bore catheter. So this is that whole algorithm, and it's available in a PDF form on the Emergency Medicine Cases website on the case notes for the episode. Again, it is definitely more of a European approach, but it is based on the best evidence we have out there. You can see it's a time-intensive pathway. You can see if you go down sides of the certain areas of the pathway, you're repeating a chest x-ray 4 hours, you're getting another one another hour, and then repeating another one in 4 hours. So we're talking about a 10-hour stay in the ED after determining this patient has a pneumo. So with things like observation units, it is useful, but there are many hospital systems, possibly including ours, that you would just say, you know what, might as well just admit this patient to get them proper observation overnight. But I think it's a great pathway to have in the back of your head to know what the evidence at least points to and know your options out there. It's also good to know what you have in your shop. These are different devices that different places use. I've actually used one of these before on the right side there, and it's a proprietary device that you place on the patient. It essentially is a very small catheter that's placed almost like an IV catheter that goes into the chest, and then it has a little canister there, and you can hook it up to suction too if you need to, or hook a syringe up to it to aspirate. And patients go home with this. So I've had lung cancer patients who do not want to be in the hospital at all. They want to do anything they can get out of the hospital. I've placed one of these before to then be able to send them home with follow-up with their primary care. So going back to our initial 2 patients we talked about, again, this comes in many different flavors. On the left, we have our 25-year-old male. So he's status post-coughing fit, has no other problems. And on our right, we have our COPD, or a possible COPD, because he's been a smoker for a long time, 55-year-old male. So that guy on the left, he had mild symptoms, just a little bit of pain. Repeat a chest x-ray in 4 hours. He seems to be a reliable patient. This patient is a good candidate for no intervention. You actually just charge him home with precautions. You'd probably keep him in the ED. Like I said, just at that 4-hour mark, make sure there's no changes, no evidence of an air leak. Phone follow-up in 24 hours. This is that patient that I would hand my card to and say, hey, call me, email me, whatever, or what's your number? I am going to call you tomorrow. That's the right patient to do a personal follow-up phone call with and make sure everything's going well. And then rechecking either an ED or urgent care or PCP in 48 hours. The other patient on exam, he was tachypnic, he is hypoxic. Based on his history, we think he probably has COPD, so it's probably actually a secondary pneumothorax. This you could get away with initial pigtail placement. Again, repeating that chest x-ray, make sure you're not having worsening of the pneumothorax. And then you can consider a Heimlich valve or hooking to suction and likely admit this patient. Most of the patients that we admit are probably going to go to suction or water seal just to make sure we can evacuate that pneumothorax as fast as possible. And in terms of pigtail placement, we won't talk about this whole subject in and of itself, but at this web address here is the link to the YouTube video of EM Cases that did a fantastic video on different tips and tricks for placing a pigtail catheter. So that's it. Once again, this web address has this lecture recording at it. I hope this was useful, and have a good day.